It's a pleasure to be here talking to you today. I am Dr. Marianela Jordan. I'm a clinical assistant professor of pediatrics at USC Keck School of Medicine, and I do my clinical work at Children's Hospital Los Angeles at the Center for Trans Youth and Development. So we're going to talk today about how to assess for gender dysphoria in pediatric patients according to their developmental stage. So as you may imagine, the assessment is not the same for someone who is 4 years old or 17. So we're going to be talking about that. I do not have any relevant conflicts of interest, no financial disclosures, sadly. And I just want to make an acknowledgement. Gender-affirming language is constantly evolving, and terms that were used in the past may not reflect currently accepted practices. And in the same way, the terms that we use today may not be appropriate in the future. So I am striving to use respectful and inclusive language in this presentation, but I recognize that language is dynamic and it may change over time. So my intention is to communicate with sensitivity and respect, and I am committed to continuous learning. So if you see a term that is outdated, that there's a better term for that, I would really appreciate it if you could let me know. I welcome feedback and I value other people's input to create a more inclusive environment. During this presentation, I will be using the word transgender as an umbrella term for people whose gender identity differs from their sex assigned at birth. So including also, non-binary or agender, other identities. Just a quick intro about our practice at Children's Hospital Los Angeles, our Center for Trans Youth Health and Development. It was established in 2012 as a center per se, but we started seeing patients for this purpose in 1994. We are the oldest youth-specific program in the United States. And in March of 2020, yes, with COVID, we launched our surgical services program. We currently have more than 2,600 patients in care, and we see patients aged 3 to 25. And the services we offer is medical care, navigation support, mental health, social support groups, and surgical services. Now, I just want to do a very quick intro. Probably most people have seen the gender unicorn or the genderbread person or some other variation of this, but a very brief discussion of the basics of people's identity related to sex and gender. So it is important to remember and remind caregivers when we're seeing a patient. And I'm going to talk about caregivers because I'm a pediatrician, so most of the times I have patients there, and usually the patients themselves are well informed about all this, but things are confusing for caregivers. So a lot of the initial appointment is education to the family. So this is something that we need to remind caregivers of, that all of these components, gender expression, sex assigned at birth, sexual orientation, and gender identity, are independent from each other. So while most people's sex assigned at birth, gender identity, and gender expression are aligned and present with a heterosexual sexual orientation, all combinations of these components can be present and are normal aspects of human diversity. This is not an illness. It's completely normal. In my experience, one of the toughest things for families to understand is that gender identity does not always correlate with gender expression. So I have seen many families who, for example, don't understand how their child who says that he's a trans boy or a trans guy sometimes likes to wear makeup. And parents are like, well, if he really was a boy, he wouldn't be wearing makeup. And it's part of the education that you need to give parents. So before talking about trans identities, let's talk about the development of gender identity in terms of, milestones. So by age 2, children start recognizing the physical differences between boys and girls, okay? By age 3, most children can easily identify themselves as a boy or a girl. And by age 4, the majority of children have a stable sense of their gender identity. So this means that, between the ages of 3 and 5, children can comprehend their gender identity. And by this age, they have also learned gender roles. This means what girls do or what boys do. However, trying out the stereotypical activities of the other gender is a normal part of development, and by itself, it doesn't say anything about their gender identity. So if the little boy who has a sister that has dolls starts playing with dolls, that doesn't mean that that little kid is a trans girl. Maybe, may not, but by itself, that doesn't say anything about gender identity. But we also need to understand that gender is not confusing for children. What is confusing is being told that you are a gender that you are not, or being told that you cannot do certain things you like doing because of your gender. Research shows that even children who are gender diverse understand their gender as clearly and consistently as their cisgender peers, and they will thrive if they get the same level of love, support, and social acceptance. So, while many young children who identify with a gender different from their sex assigned at birth can express it by simply saying, "I am not a boy, I'm a girl," others express it non-verbally through stereotypes. Stereotypes is what they have learned that society tells them that girls or boys should do, wear, or like. However, we should remember that these stereotypes and gender roles are social constructs that are not rules. So the fact that someone's favorite color is blue doesn't mean that they're a boy. And these stereotypes also vary among different cultures and times. For example, it is now very common to see women wearing pants, but this was not socially acceptable in the, until the mid 20th century. I have a small anecdote, a patient I saw recently so this patient gets to my office at age 6, and this is a trans girl. And the parents tell me, you know what? We took this kid to speech therapy because we thought that she had a language problem, like a problem with comprehension, because she kept saying, "I'm a girl. I'm a girl, I'm a girl." And the parents were like, "No, you're not a girl, you're a boy." And then the kid would be like, "Okay, then I'm a boy, like mommy is a boy." "No, mommy is a girl, you're a boy." "Okay, if mommy is a girl, then I'm a girl too." And the parents were like, "This kid has some issue, like they don't understand the difference between boy and girl." And they later realized that it was that this is a girl actually. So now, something that I see very often is families thinking, when the kid is 4 years old or 3 years old, they're like, "Oh, they're too young to know." But then when the kid is 14 years old, when they first say something, they're like, "Oh, they're so old now. Why didn't they say something when they were younger?" So this teaches us that for some families, it is never a good time for their children to come out and say who they really are. So for those who present before puberty, it is important to remember that a child that was assigned male at birth, for example, that wants to wear mom's high heels, that doesn't mean that they're a trans girl. However, if they are consistent, insistent, and persistent in their gender identity, recent research shows that the vast majority of children, prepubertal children, who endorse this gender identity will continue to endorse the same gender identity later in life. So people usually say, "Oh, they're children, they don't know. We have to wait until they're in puberty or after puberty." But recent research shows that the vast, vast majority will continue to endorse the same gender identity. At the same time, some people may not confront their gender identity or may have felt compelled to conceal their gender diverse characteristics until they find an affirming community or environment, or until the distress caused by gender dysphoria is way too big to suppress, which usually happens in puberty. So, why do some people don't realize their gender until after puberty? We also need to remember that adolescence is a critical period for identity exploration, experimentation, and questioning of social rules. So it may not be until then that these kids start thinking more seriously about these things. Also, external factors like societal expectations, transphobia, which, little asterisk here, I decided a couple of days ago that I'm not going to use the term transphobia anymore. A more correct term is transmesia. For those of you who don't know, transphobia, the root of this word comes from the Greek word phobos, which means fear. And I am convinced that this is not a matter of fear. This is a matter of hate. Also, when we use the term phobia, sometimes we use it for certain psychiatric conditions like arachnophobia or things like that. So it makes it sound like it's something more at the individual level. On the other hand, the term transmesia, misos is a Greek word for hate. That's where misogyny comes from, misandria comes from. And it also is better at acknowledging the role that it's not an individual thing, the role that institutions and systems play in the oppression of the rights of gender diverse people. Sorry about that. I need to update my presentation. But okay, so societal expectations, transmesia, negative messages in the media like bans on gender affirming care, and even internal factors like temperament or internalized transmesia can influence a person's ability to explore or voice their gender identity in childhood. In my clinical practice, patients who present in late adolescence or young adulthood, they very, very rarely tell me that they never had any sort of discomfort or feeling of something being off or not matching. What they often say are things like, you know, I did not know that I had the option to not be a boy or a girl, or I thought that everyone felt that way during puberty, or I always knew something was different about me, but I did not have the language to say it or even think about it. Or things like, I knew, but I was afraid my family would not accept me, or I kind of knew, but I could not accept it myself, so I tried really hard to be a boy or to be a girl like I was supposed to. These are the things that I hear in my practice. So now that we have talked about how and why transgender people present at different ages, now I will talk about the assessment of a patient who presents with concerns for gender dysphoria. So what is gender dysphoria? Let's talk about the definition. So having gender dysphoria is not the same as being transgender. Being transgender is a natural component of human diversity, and some transgender individuals do not experience distress related to their body. Gender dysphoria, on the other hand, it is a medical condition. It significantly affects mental health, quality of life, and it requires treatment, and this treatment is medically necessary. The treatment for gender dysphoria is gender-affirming interventions. In other words, we change the body, we change the self-image, we change the social perceptions. We do not change the internal sense of self. You know, for a long time, people have tried to do that, like changing the internal sense of self with things like conversion therapy. But now we have learned that number one, doesn't work. And number two, attempting it is actually very harmful. So gender dysphoria is a distress that arises from an incongruence between an individual's gender identity and their sex assigned at birth. And this can manifest like through aspects like their physical body, the bodily functions, the societal perception, or their self-image. Now we're going to talk about the diagnostic criteria. So the Diagnostic Statistical Manual, DSM-5, you know, the big Bible of psychiatric diagnosis, has this set of diagnostic criteria so you can assign someone the diagnosis. Before we talk about this diagnostic criteria, I would like to express some reservations about them. Personally, I don't love them. I find these criteria to be limited, particularly in their application to children, because I find them, I think that they are directed towards children raised in predominantly cis-normative environments. For instance, the criteria for children rely heavily on stereotypes, which, while some children may actually use to articulate their gender identity, are ultimately just stereotypes. And also, it is very binary. It leaves out other genders that are not fully feminine or masculine. And I think that the primary utility of these diagnostic criteria is more administrative. Like once you assign someone this diagnosis, then you can bill insurance for this, rather than truly capturing the diverse experiences of gender identity and how they impact patients' lives. So for example, the criteria for children. I'm going to go very quickly through this because it's boring. It's a lot of words. You can find them in the DSM-5. But the first diagnostic element we have is an incongruence between someone's experienced or expressed gender and their sex assigned at birth. Then we have a timing factor. This incongruence has to have been present for at least 6 months. Is this length of time 6 months based on science? No. But it is what people have chosen to use as an objective measure to the concept of consistency, insistence, and persistence of gender identity. Now, this incongruence has to be manifested by at least 6 of the following components, one of which has to be the first one: a strong desire to be of the other gender, or an insistence that one is the other gender or some other alternative gender. So the other 5 components that you can choose from are a strong preference for cross-dressing or the attire of the gender the child identifies with, preferring cross-gender roles in fantasy play, a strong preference for the toys, games, or activities that are stereotypical of the other gender, a strong preference for playmates of the other gender, a rejection and avoidance for the stereotypical toys and activities of their sex assigned at birth, a strong dislike of their sexual anatomy, a strong dislike for the primary or secondary sex characteristics of the other gender. And then it tells us that the second component of the diagnosis is that there has to be distress or impairment as a result of that gender incongruence. There's another aspect of the criteria where I would make an adjustment. You know, since children have not developed secondary sexual characteristics yet, when they are raised in supportive and affirming environments where they are allowed to be who they really are, they will not have this distress or impairment. So in those cases, the question I ask myself is, would this child experience distress or impairment if they were not supported in their gender identity? So for example, someone who was assigned male at birth and wants to wear dresses and play with dolls, if their family tells them you cannot do that, then yes, they will experience that impairment or discomfort and distress. But if they're in a supportive environment where people are affirming, then they're not going to be experiencing that distress. And we actually call childhood, like, it's usually like a honeymoon period where the child is usually happy if they're in a supportive environment, but then puberty comes and that's when things start getting tough for the child. Now, for postpubertal patients, the criteria change a little bit because they now incorporate the reactions of the individual to their changing or changed body, and they rely less on stereotypes. So we still have the timing of at least 6 months, but now we only need 2 of the components below, and they can be any of them, whereas in children, the first one had to be present. And the first 3 components talk about secondary sex characteristics, incongruence between them or the anticipated ones and their gender identity, wanting to get rid of or prevent the development of them, and wanting the ones of the other gender or the other sex. This part is also problematic for people who are non-binary, because what are the secondary sexual characteristics of a non-binary individual? Like how do you diagnose wanting the secondary sex characteristics of a non-binary person? And then there is a desire to be of the other gender and to be treated as the other gender. And the final one is also very problematic: a strong conviction that one has the typical feelings and reactions of the other gender. Like, this is also based on stereotypes. What are the typical feelings and reactions of a non-binary person? What are the typical feelings and reactions of a male? Like, does that mean not crying? Like, who says that? It's anyway, I hope we get some better diagnostic criteria sometime soon. Finally, it also requires the presence of distress or impairment as a consequence of this incongruence. But now let's go to the less boring part. Assessing, how do we figure out if a patient has gender dysphoria? How do we turn the previous boring slides into a patient encounter? So please take into consideration that The initial assessment for gender dysphoria takes at least an hour and sometimes has to happen over more than one patient encounter. First off, context matters, so I'm going to share some helpful tips on how to have the appropriate setting for your assessment. So, a welcoming environment. You will be asking very personal questions, so it is important to create a welcoming environment where the patient will be more likely to feel comfortable enough to share. When we talk about location, this may mean doing a telehealth encounter for patients who would feel more comfortable at home, or making sure that all the staff at your clinic are trained to provide an affirming environment that should start by using always a patient's affirmed name and pronouns. I recommend obtaining this information from the caregivers at the time the appointment is made, so the staff can use them at all times since the patient steps into your clinic, and also making sure that all materials that will be seen by the patient include their affirmed name. Many electronic health records still will show a patient's legal name, but at least including also their affirmed name. Other things that can make an environment welcoming are signs or ornaments that show that the healthcare team is supportive of LGBTQ patients. And this can be a poster in the waiting room or in the wall of your office, including your pronouns in your ID badge, wearing a pin, or having stickers on your personal belongings. Also, for culturally sensitive care, if you need an interpreter, try to arrange for an in-person interpreter or a video interpreter. It's using a telephone interpreter is okay when you're talking about diarrhea, but these things that have a deeply cultural and personal implications, it's better to do it with an in-person interpreter. I mean, ideally with a provider who speaks the patient's or the family's primary language, but the next best thing. But also remember that culturally sensitive care is so much more than using an interpreter. You should aim to be open about different belief systems and cultures. Being open does not mean supporting points of view that could harm your patient, even if they are part of a culture, but rather providing education to redirect these beliefs without judging the person who holds them. That is the trick. And finally, providing a welcoming environment for patients to talk freely also means having a private conversations with adolescents. Now, who should be there? In minors, you will obtain a history from the patient, but also from the persons that come with them. This encounter should include the patient's main caregivers, who should ideally be the people that the patient feels most comfortable being themselves around, and who have seen them grow and develop, and who have seen the things that you will be talking about. But ideally, all legal guardians, if different from the caregivers, should also be present, especially when there is a disagreement amongst them. Even though no medical interventions that require consent of all legal guardians are usually started in the initial visit, it is a good opportunity for everyone who would have to eventually consent for gender-affirming interventions like puberty blockers, hormones, or surgeries to get some knowledge regarding gender diversity in youth and it's also a good opportunity for them to ask questions. In my experience, it is common for patients to not share their struggles with their parents, either because they don't want them to worry too much or because they think they would not understand or accept them. So it is useful for them to for the legal guardians to hear the full story to better understand their child's situation, especially guardians who don't see the need for interventions. So for example, sometimes I have patients who tell me, you know what, I struggle a lot with voice dysphoria. And then when we talk about interventions to help that, the parents are like, oh, but my child seems fine. My child is okay. They're passing all their classes, they go out with their friends. And it's usually because of this. The child doesn't share their struggles with the parent. If the patient doesn't feel comfortable sharing their story with their legal guardians in the room, then the provider can have this conversation in private with the patient and then offer to help facilitate conversations to the extent that the patient is willing to share. So never share more than the patient wants you to share, but try to make the patient understand the importance of sharing some of the story. Then pronouns. To start the encounter, what I do is I introduce myself and I include my pronouns every single time, even if they're stated on my ID. So I will say something like, hi, my name is Dr. Jordan. I use she, her pronouns. What are your names and your pronouns? So this will sometimes result in the patients and the caregivers modeling the same behavior and including their pronouns when they introduce themselves. If they do not include their pronouns, I explicitly ask them about it. So, oh, okay, so you're mom. Mom, what are your pronouns? This helps normalize the concept that you cannot tell a person's pronouns or gender by looking at them, and is a good way to introduce a conversation that will follow. But also, for example, terms like mom are gendered. So I've had caregivers who will say their name and they will tell me sometimes, oh, my pronouns are they, them, or whatever. And then I ask what terms they're comfortable with. If they want me to say parent, if they want me to say, caregiver or mom or whatever they prefer. So then also what to expect. So it is helpful to set expectations for the visit. To do this, I have a speech that I always use after introductions, and it goes something like, welcome to our clinic. I will be taking care of you today, and I will try to answer any questions you may have. Then I call the patient by their name, and looking at them, I add, I also know that you may be feeling anxious right now. I want you to know that this is not a test. You do not have to prove your gender to me. I believe you. Today, I will be very nosy and I will be asking a lot of questions, many of them quite personal. And while getting these answers will help me better understand your situation and offer you resources that may be of help, I also understand that I'm a stranger and it can be hard to open up about these things. So if you don't feel comfortable answering a question, just say next and we'll go on. And I also add something like, I know you have a lot of questions, and while it is okay to ask them along the way, some of those questions may be better left for the end after I know more about your child and your child's case, and then I can answer specifically for their case instead of saying, well, it depends. So this is a way to set expectations for the visit. Now let's go to the actual interview. My very first question is, what are your goals from this visit? And I ask this to the patient and to the caregivers. This will dictate the direction that the encounter will have. In my experience, the patient usually says their goal is to start gender-affirming interventions. But the conversation will be very different if the caregiver shares this goal or if they're still not on the same page about the patient's gender identity, for example. Very sadly, I've had one or two families where the caregivers told me that they were interested in conversion therapy. So yes, these are very different conversations. So it's very good to ask this question before you start talking. So after asking permission to talk about gender, my first question is for the patient, and it is, what is your gender identity? Some patients will immediately answer with a single word. Others may give me a 10-minute explanation. Remember that most people don't talk about these topics at home or at school, so it may be difficult for patients to come up with an answer. If I see that they're kind of doubting, I ask both the patient and the caregivers if they know what gender identity is. If not, I explain what it is, and if they do know, I also tell them that it's okay to not be sure or not know, and that it's also okay if the answer is a long one. When the answer is something other than male or female, I ask patients what they mean by that. So for example, if someone says they identify as queer or as non-binary or gender fluid, I ask them to elaborate. Also, sometimes I hear answers like, well, I'm a boy, but I wish I was something else, or I wish I was a girl, or things like that. I will say something like, if we don't take into account your genitals or what people think you are or should be, and we only focus on who you are in your mind and in your heart, what would that be? And then they often will say, okay, then a girl, for example. And then I say something affirming like, well, then you're a girl, period. This may lead to a discussion with the younger patients about how some girls have a penis and some boys have a vulva. But I use the words that the child uses for these terms after asking the parents. And this question will give us an answer to one of the diagnostic criteria, which is the desire to be of the other gender or some alternative gender. I really like this worksheet. This is by social worker Darlene Tando. she made it for younger children who may lack the vocabulary to express who they are. You can either print it out and give it to the patient, or as I do, just explain the information here and then ask the questions. You say like, well, some people are born with boy bodies and they have the heart and the brain of a boy, and some people are born with girl bodies and they have the brain and the heart of a girl, but some people are born with boy bodies, but they have the heart and brain of a girl, or vice versa. But then also some people feel like both a boy and a girl, or some people feel like neither a boy or a girl. And you may be asking yourself, how does a child, a 4-year-old, express feeling neither being a boy or a girl? And this is one part of my job I really love. Children can be very creative. I've heard the most amazing answers to this. For example, one patient said, well, I'm not a boy and I'm not a girl, duh, with a face like they're wondering if I'm stupid or why I didn't get that. I also have a patient who identifies as non-binary, and on their initial assessment when they were 5 years old, they told me that they wanted to be a droid because droids didn't have to be boys or girls. And actually their affirmed name at the time was R2D2. Another kid told me that they wanted to be a tree, but specified that they wanted to be a tree that could move, because trees didn't have to be boys or girls. Now, for older patients, I may use drawings like this to get the young person to explain where in the gender spectrum they are, or if they are outside of the gender spectrum, which may be the case for agender people. And also, if they're always in the same place within the spectrum, or if it changes or flows, and if so, along which portion of the spectrum it moves. Now, if the patient this happens sometimes. Some patients, more commonly the prepubertal children, will just not want to talk to you. I usually start by asking if there's something that will help them feel more comfortable, like playing a game on their phone, or playing music, or holding a toy, or some patients even like want to go under a table and speak from there, like hiding. That's okay. If they say no, then I will ask them if they are okay with me talking to their caregivers about it. And if they are, then I ask the caregivers what the child has said or done regarding gender. If they don't want you to ask about this topic, then I ask permission to talk to the caregivers about boring stuff unrelated to gender. And in those cases, I go on to obtain a past medical history, family history, in the hopes that the patient will feel more comfortable talking about gender in a future visit. But sometimes the patient doesn't want to talk to you. So I usually ask the caregivers to not scold the child about this and to talk to them at home about what happened. I also will contact the parents at a later time to ask what they think may help, or if they think their child is not ready to have a medical visit about gender. Of note, I always ask at a later date, like by calling the caregiver on the phone, for example, instead of asking the child to leave the room. Because if you stay with the parents in the room and ask the child to leave, guess what? You're only going to decrease your chances that that child is going to trust you. So these are some tricks for that. So before I start asking about their gender story, because I want to know how they developed, in what context all of this happened, I will say that I will ask some questions to better understand their gender journey and in what context it has happened. I will also ask caregivers to let the patient answer first, and then I want to hear the caregiver side of the story afterwards. In some cases, especially with adolescents or older children, if appropriate, if I see them hesitant about talking, I ask for permission to talk to them in private, and I ask the caregivers to step out. Remember to always start any private conversations with a disclosure about confidentiality, what confidentiality means, and what things would make you have to break confidentiality. So I usually ask patients about their gender story and mental health in private, and then ask them if there's anything else they would like to share before calling their caregivers back in their room. And then I ask if it would be okay to share with their caregivers some of the information the patient told me, agreeing with the patient on exactly what things will be shared and to what extent. I also ask them if they would feel comfortable telling their caregivers themselves, explaining why this may be important, and offer to facilitate the conversation. In other cases, if I detect that a non-supportive caregiver is saying things that are causing distress to the patient, I will ask to have a conversation in private with the caregivers, making it also a good opportunity to educate the caregiver and talk about the importance of family support while protecting my patient from this distress. Now, to talk about a patient's gender story, I divided into two sections, coming in and coming out. Coming in is not an official term. I stole it from my mentor, Dr. Olson Kennedy. So I usually tell patients, well, you know how everybody knows what coming out is? Coming out is telling the world who you are. But there's usually a process before that I call coming in, which means that like the process of how you found out who you were before you could tell the world, who you are. And, I have never had a patient tell me that they were feeling completely fine. And then one day they went to bed and woke up the next day and said, oh, I'm transgender. Rather they tell me that they usually feel uncomfortable for a while or like something doesn't fit. Some people know right away it's a gender thing. Others may think that they're, gay sometimes, or sometimes just feel uncomfortable and don't have any idea why. And then they think about it for a while. They may go through a period of denial or trying really hard to make their gender align with their sex assigned at birth, but eventually they realize that they cannot do that and finally accept it. So what was this process like for you? I will hear their answer without interrupting. And then if I need more detail, I'll just ask questions, like when did you first feel like something was off? When did you first realize your gender? Did you previously identify with other gender identities before the current one? Did you make any changes to your gender expression? When? How? How did that make you feel? So I also acknowledge that changes to gender expression are based on stereotypes and do not dictate gender identity. So, so for example, I let the patients know that there's no wrong answer, that if they identify as female, but they haven't let their hair grow long, that doesn't mean that they're not a girl. So this is about this, and this will give us information for some other diagnostic criteria, like the strong conviction that one has the typical feelings and reactions of the other gender, the duration, at least 6 months, the strong desire to be of the other gender, the strong preferences for girl-boy clothing, marked incongruence between one's gender and sex assigned at birth. And then I asked the caregivers about the patient's gender story, and I will ask things like, did you ever notice anything different about your child when they were growing up? Did they ever say they wanted to be of the other gender? What were their preferences in clothing, friends, activities? What did they like to play, like when playing, what characters did they choose? What did they want to dress up for Halloween? That gives you so much information. And of course, this will give you information about other diagnostic criteria. But conversations can get complicated, especially when patients and caregivers are not on the same page. Always remember that you do not have to agree with someone to be able to see why they may feel or think a certain way. You should always validate everybody's experiences, but always be supportive of your patient. An example is when a caregiver tells you that hearing that their child is transgender was a really bad thing. You can answer that. You can see how that can be difficult as a parent, but that is who their child is, and it's not something that the child did to the parent. So you never have to agree with a non-supportive parent, but you can validate their feeling anyway. The last thing, sometimes you hear some things that make you want to say, no, like, you're wrong, get out of here. But you have to think about what will be best for your patient. And the best thing for your patient is to have that family come back so you can continue to provide more education. So coming out, I asked them, who was the first person you told about your gender identity? What was their reaction? When did you tell your family or your caregivers? How did they react? What is the situation like now? Do they use your correct name and pronouns? In what aspects of your life are you able to be who you are? Who is supportive? And this will tell us about distress and impairment. And then I will ask the caregivers things like, was it a surprise when your child told you? What was your reaction? What are your thoughts about your child's gender identity? And here we also have differences. So when I hear the gender story of a patient who came out in early childhood, the coming out and the coming in and the coming out processes are usually happening at the same time. especially if they're in a supportive environment. So a child needs to feel safe and supported in order to be who they are, but sadly, this is not always the case. And this can complicate the assessment. For example, I have a 6-year-old patient who shared with their parents how they felt from an early age, and while the mom was super supportive, the father made negative comments about them playing with certain toys or preferring certain clothes or activities. So now the child is who they really are when they're with the mom, but they refuse to wear the clothes that mom knows they prefer and bring their favorite toys to school. So, and then when someone comes out around puberty or in adolescence, they usually realize who they were. They thought a lot about it without telling anyone. And then one day they tell their family, and it is a big surprise for them. And the caregivers say it came out of nowhere, that it was very sudden. So there is a disconnect because the child has thought about it and processed it for a long time. And they reached a point where the distress was so big that they needed to tell their caregivers. But now their caregivers have to go through the same stages to process the news. This is complicated because the patient's distress is usually high at this point, and they need acceptance and they need interventions right away, but the parents are in shock still, and they are usually not prepared to help their child at that point. So after asking about their gender story, I asked about school and or work. For example, do people at work or school know that you're trans? Is it an affirming environment? How are you doing at school? How are you doing in your work? Do you miss any days and why? Is there any bullying? Is there any discrimination or harassment? Are you able to use the bathroom that you want to use? Do people use your correct name and pronouns? And this will also give us information. And then we go to what I call then we go to mental health. I ask about, this is ideally done in private for peripubertal children and adolescents. Remember that one of the complications of gender dysphoria is thoughts or behaviors of self-harm. So always, always ask about this. I start by acknowledging that while mental health issues are more common in transgender people, this is not because there is something wrong with the brains of gender diverse people, but rather there is something wrong with the society where gender diverse people live. So I will ask about symptoms of or diagnosis, when did those start, severity, triggers, treatments, suicide, suicidal thoughts, non-suicidal self-harm, disordered eating, which is sadly more common in gender diverse people, and if there's any overlap between their gender dysphoria and mental health. And then it's time to talk about triggers for gender dysphoria. At this point, we've had a very heavy conversation, so I check in with the patient and see if they are okay to talk about another hard subject. Gender dysphoria is not a favorite topic. And then I tell them that after this, if they're okay with continuing, we'll take a break and talk about boring stuff. If they tell me that it's been too much emotion for one day, then we'll leave this topic for the next session. But I start by asking if everyone in the room knows what gender dysphoria is. If not, I will explain it. And I also explain that not all trans people are uncomfortable with their body. And if they are, it can be just one thing or it can be everything. And none of this makes anyone any more or less of a woman or a man or whatever their gender identity is. I also say that I will be talking about body parts. And if this is a young child, I will ask the parents what terms they use to refer to these body parts, or if they're older, I ask if it's okay to use anatomical terms or if they prefer to use other terms. Even if the patient says it's okay to use anatomical terms, I only use gender terms if absolutely needed. Otherwise, instead of saying penis or vulva, I will say genitals. Instead of saying periods, I will say cyclic bleeding. Instead of saying breast, I will say chest. And then I ask what parts or functions of their body they would like to change. For a younger patient, I will say something like, if you had a magic wand, what would you change about your body or about the functions of your body? And then to peripubertal children, I will ask if they are aware of how their body will change when puberty happens. How would you feel about that? To children, I ask, do you feel comfortable taking a shower? I also ask parents if their child has expressed discomfort with their body, like a patient of mine, a 3-year-old, who the parents walked in the room and found this child with scissors trying to cut off their penis. Gender dysphoria shows in all those ways. And in children, I ask them if they know what they would like to look like when they grow up. Like, you know how mommy and daddy are different. Dad has a mustache, mom has boobs. When you grow up, do you want a mustache? Do you want boobs? You know, things like that. I love it when kids tell me, well, I want to look like myself. I love that. Um, so, and then I ask specifics, you know, for adolescents, like if they tell me, oh yeah, I'm not comfortable with my body. Well, what about your body? Is it the shape? The shape where? In your hips, in your shoulders? Like, what is it? I also ask about spontaneous erections, cyclic bleeding, and this information will help you figure out the patient's embodiment goals and thus like what treatment can help. Uh, and also ask the patient about the impact of gender dysphoria in their life, in their mental health, in their well-being. And lastly, I ask what interventions they have adopted, either prior use of gender-affirming hormones, prior use of puberty blockers, surgeries, medications for menstrual suppression, or non-medical interventions like binding or tucking. And if so, I ask how they do it to make sure they're doing it in a safe way. I know we're running out of time, so we're almost done. Then we go to what I call the boring questions. Who their primary doctor is. I ask about their past medical history, asking specifically about mental health and illnesses whose risk may be affected by gender-affirming hormones, like high cholesterol, any personal or family history of myocardial infarction or stroke, thrombosis, cancer, autoimmunity, bone fractures in someone considering puberty blockers, what medications they take, what supplements they take. And then I ask about what has happened with pubertal development. Don't ask when did puberty start, because people usually will tell you when they got axillary or pubic hair. But axillary and pubic hair are the result of androgens produced by the suprarenal glands, not by the testicles or ovaries. And we want to know when gonadal puberty, you know, puberty triggered by the testicles or ovaries started. So for early puberty or peripubertal children, it is beneficial to do a physical exam to determine the Tanner stage or the sexual maturity rating, because that will give us information about when it is time to start interventions and what interventions would be most helpful. For example, puberty blockers in someone who is in early puberty versus going straight to gender-affirming hormones in someone who's more advanced in their pubertal development. And then fertility. This is going to be the first of many discussions. This talk about fertility is just to get a sense of where you're starting from and to get the patient used to talking about this. So I will ask them decide about whether they want to have children in the future or not. And this is, I feel very weird asking this to a 7-year-old. But like I said, this is just to establish, like, to start talking about this subject. And I ask them, how important would it be for them to share their DNA with their children? Meaning if they want to have biological children. Do they see themselves doing it independently or with a partner? And if it's with a partner, like this is probably for older people, like for older patients, what like do you see yourself with a partner that will produce sperm or with a partner that will produce eggs? If there's any desire to carry a pregnancy, if there's any desire to chest feed, and what do caregivers think? And these questions are because this is not part of this talk, but some gender affirming interventions will impact fertility outcomes. And so I'll be happy to take questions. Sorry that that was a little rushed, but it's a very long visit that you have to have in your initial assessment. Oh, I see the chat here. Oh, I don't see any questions. If anyone has any questions, please feel free to unmute yourself or put them on the chat, whatever you prefer.
Yeah, I had a question.
Yes.
So I think you mentioned sometimes when there's incongruence between what your patients want and then caregivers. For example, I think the anecdote you gave was about a caregiver coming to you asking how to start conversion therapy. Um,
Yes.
how do you address that? Because I guess as a pediatrician, there's one responsibility of like advocating for the patient,
Yes.
but then I guess their caregivers are also kind of an extension of the
Yep.
pediatric patient, right? So how
Mhm.
do you, I guess you have to make everyone happy, but then also advocate. Yeah.
Let me tell you something. Gender affirming care The part about knowing what hormone to start and what dose and when to increase the dose, that's super easy. The hard part of gender affirming care is what you're talking about. That is the art of it, and that it takes a long time to figure out how to. You need to be very intuitive to kind of to understand what the parent is thinking, and like I said, always be like, for example, that a family that says, "Oh yeah, you do offer conversion therapy, right? Here, right?" We're like, "Okay, what do you mean by conversion therapy?" You know, and then have a talk about what gender identity is, and what you know, yeah, like go through what that is, and then ask like, okay, so what are your concerns? It sounds like this is concerning to you. It sounds like this has been difficult for you. Tell me, how has this been difficult? And then I acknowledge the difficulties that they have faced, but I also show that the caregiver difficulties that their child is experiencing. And this is the point where if I have a family who is like, no, that is wrong and that is evil and whatever, I will try to have that conversation in private to not traumatize the child, and try to talk about, usually my resource is, okay, let's just go back to the beginning. I just want to make sure that we have the same goal in mind. My goal here, I know that you love your children. You love your child. Let's just say that we're all here and our purpose is for your child to be happy. Is that okay? Is that right? And when they acknowledge that they want their child to be happy, then I'm like, okay, does it matter if your child is happy in a dress or playing soccer? Like, try to go back to the basics. What we want is for your child to be happy. And sometimes they're like, oh, but I don't believe they're a boy. Okay, even if you don't believe that they're a boy, but do you acknowledge that for you to call them with this name and these pronouns will make your child happier? Kind of trying to go back to the basics. I would love to say that it works every single time. It doesn't. That's why sometimes this initial assessment can take, I have a patient that I've met for 6 1-hour visits, and we still haven't talked a single thing about interventions. We're still on the this is your child part.
Thank you, Dr. Jordan. Appreciate it.
As the Wi-Fi.
All right. I think we finished up our breakout rooms. Really quickly before everyone leaves, thank you, first of all, to Doctors Chen and Jordan for providing some amazing presentations and for your time. I think we really wanted to just go over very briefly, for providers, there's an LGBTQ plus healthcare directory. And essentially it takes like 2 minutes to sign up for this. You can kind of go to this website. It's just tinyurl.com/LGBTQ dash directory, and you put in your essentially your name and email, or name, specialty, practice. And this directory is a way for queer patients to provide or to find providers that are essentially affirming their rights, and these providers, it's like a list of competent, sensitive healthcare providers. So it's just a directory of providers who can advocate for queer patients. And yeah, I don't think there's it's not too complicated to sign up for that. It just makes you available and visible to queer patients. So yeah, that's a great website. And then also free clinics for patients who need STI testing and have a hard time getting that through their primary care provider, or making appointments because it's expensive. They're on their parents' insurance and can't really talk to them about those kinds of things. Going to free clinics is a great option. This QR code actually will take you to a map of all the free clinics in California. And then there are also these websites, nafcclinics.org and californiafreeclinics.org. And these can be great to send patients to, especially for those who have difficulty obtaining or accessing care. So that's another great option. And that pretty much wraps it up. This is a QR code for getting the CME credit. Thank you all so much for joining us. And then Wayne, if you want to share last words.
Yeah, of course. Again, thank you everyone so much for attending. For the pre-healths and pre-meds in the audience, please keep this in mind as you head through your schooling, head through med school, PA school, PT school, wherever, and consider this inclusion as you head into your practice. Hopefully, maybe you can register on the LGBTQ directory. I know it's a pretty new website. It started around 2022, so I've kind of been seeing it grow kind of on the sidelines and cheering it on. We have an extra slide in our slides here, which we're going to send out afterward, about pronoun usage, why it's important, and a website, pronouns.org, if you'd like to check that out when you have the time. And again, for our providers and presenters in the audience and in the presentations, thank you so much for all that you do for queer patients, for your patient populations, and for these amazing presentations. I've learned a lot today, and I really do appreciate all of you for showing up and showing your support as LGBTQ members or allies. Thank you, thank you, thank you, thank you.